And welcome to the first Facebook Live event here at Stanford Healthcare. I'm Lisa Kim. Thanks for joining us tonight. We're going to talk or have a heart-to-heart about your health, specifically heart health, matters of the heart when it comes to symptoms, treatment, and also going beyond the diagnosis. And joining us tonight are some of the top cardiologists here at Stanford Healthcare, Dr. Abha Khandelwal, Dr. Marco Perez, and Dr. Nicholas Leeper. Again, thanks for joining us tonight. I know you all had a big and busy clinic day, so thanks for giving us your advice tonight. You know that heart disease is the #1 killer here in the U.S., and it affects all ages, all ethnicities, and also gender, men and women. So let's talk about women. Here's something that's very troubling, a stat that 1 woman dies every minute because of heart disease. Why is that?
Well, that's a complex answer, Lisa. I think there are many reasons why this happens. One is that traditionally when women present with symptoms of a heart attack, they often have several symptoms. It's not just coming in with the traditional chest pain. Sometimes they may present what we say atypically, so with trouble breathing, with indigestion, some other types of symptoms. And where you're seeing that statistic be very true is actually at either end of the age group. So our younger women that are presenting with different types of heart attacks, so not traditional, the plaque that causes your traditional heart attack. So I think that's one of the causes. I think the other big cause is that women often have multiple responsibilities, and oftentimes in taking care of those other responsibilities, sometimes are not putting their health at the forefront. And so in our group at the Women's Heart Health Center, we actually tried to attack all of those different facets of their life to try to make them a little bit more adherent with heart-healthy behaviors.
You touched on something very important. That's responsibility and being self-aware. And that's where some of the technology may come in to help you in that process. Isn't that right?
That's right, Lisa. So, we're, I think, entering into a brand new area of just healthcare and healthcare research. So we're lucky enough to live in an area where we can partner with some of the technology firms around here, and really study how we can use technology. I mean, as you know, we have technology everywhere. We have it on our phones, we have it on our wrists now. And what we're learning is that we can use the existing technology to monitor each other for certain kinds of conditions. So right now we're working with Apple on the Apple Heart Study to try to detect very early on atrial fibrillation, which is an irregular heartbeat. And that kind of condition can be associated with things like stroke. And so if we're able to detect it early on, we might be able to prevent some conditions like strokes and the side effects that you can get from that.
You look at conditions and you look at treatment, but sometimes you have to look beyond just the diagnosis, and genetics comes into play there, right?
Absolutely. I think that we're entering a really incredible new era where we can move beyond, one-size-fits-all treatments, taking care of your blood pressure, your cholesterol, and getting towards this concept of precision medicine that you've heard so much about. Cardiology is kind of lagging behind some fields like cancer, where now if you have a tumor, we can biopsy it and sequence it and figure out which mutation you have, and then hopefully give you a chemotherapy directed against your personal mutation. Now, cardiology is different. A lot of the diseases that we take care of, like heart attack and stroke, aren't caused by just one gene. It's probably dozens or hundreds or thousands of genes working together. But we're starting to accrue enough genetic information where we can start to kind of get at the root cause of these diseases. So if you come to Stanford now, you can enroll in the gene pool study, and every patient that comes through our door can donate their DNA for research purposes. We're also partnering with Google for the baseline study, which is going to do incredible amounts of characterization of over 10,000 patients. And when we couple that with the genetics that are being accrued in the United Kingdom and here at the United States, we can look at the DNA of millions of patients. And when we do that, we're starting to really get at the root cause of these complex disorders, and we're going to get to really personalized and precision medicines that are going to move from being reactive to proactive and really help us, nip this disease in the bud.
I think we discussed this before. You had coined it, the phrase, kind of like taking the garbage out.
Yeah, so my research laboratory is very interested in atherosclerosis, which is the buildup of plaque in our arteries. This is what causes heart attack and strokes. And for generations, we've known that this is caused by the accumulation of cholesterol and disease cells. And we've never understood why our immune system just ignores it. Why does it not clear it out? And now that we're able to use this, these huge genetic resources and look at all 3 billion base pairs in our DNA, it turns out there's this problem with taking out the trash, and our cells are turning on things that are called don't eat me molecules. So if you're a Star Trek aficionado, it's kind of like a cloaking device. And so the cells don't get cleared out, but we can leverage that information for our own purposes, and we can actually block that signal and stimulate our immune system to start eating out and taking out all that garbage. And then in our mice, at least, we can shrink that plaque. And so we hope to take that into humans and actually start to melt away plaque.
Mm-hmm. I think that's a perfect example, as we had mentioned before, personalized medicine, precision health. And that plays a lot, I think, into heart disease. We have a program here at Stanford with South Asians and heart disease.
Yeah, and it's in our program, we're looking at South Asians not only in the Bay Area, but actually collaborating with partners in India as well. And the unique thing about what we've seen is that heart disease occurs about 10 years sooner in our South Asian patients. And we don't have a great explanation for that. They don't have all the same risk factors. They tend not to be smoking. They tend to relatively lead healthier lives, but they still have this increased risk of heart disease and heart attacks. One of my areas of interest is looking at one of the genetic cholesterols called lipoprotein A that tends to occur in this group a little bit more frequently and may be partly responsible for increased heart attacks in this group. The other thing that we're doing in our Sathi program is piloting new ways to reach our patients, because oftentimes the South Asians in the Bay Area are very, very busy and working hard at their daily tasks. They don't take the time to get out of the office and exercise and do those things. And so we're actually helping them reach our health coaches, our dietitians in a virtual fashion so that they have easier access to that information.
And access to technology. And we already talked about the Apple Heart Study, but there's also a question of how do you get these patients, these people, to sort of latch on to the new technology in terms of monitoring their own health, specifically heart health?
Yeah, that's been a challenge, I think, that we've had in that we have all this great technology and these potential tools that we can use, but I think one of the pieces that's really missing is the research that needs to be done to prove that technology actually can help the health of others. So we always say in medicine that the research always lags behind the technology, because technology, as you know, is moving at a very fast pace. And so now we have things like the Apple Watch that has light sensors and things like that that can detect irregular pulses. But what we don't know yet is how helpful that's going to be if we start monitoring on a very large scale. And so that's why we and others are starting to do these large-scale studies to see how helpful this technology actually is.
So how do we put that research on the fast track?
Well, I think that we need to get people to buy in and participate and think about things beyond what we already know. We've had our classical risk factors for several decades, but we know from our genetic studies that even if you account for everything we know of, diabetes and high cholesterol and high blood pressure, that's only about half of our risk. The rest must be either genetics we haven't found or things in our environment. So I think learning about what we take in, learning about our behaviors, learning about things in the environment around us. So that's why we're so excited about the sensors that can deliver new data and new ways to analyze it. So thinking about ways to use really exciting artificial intelligence techniques to look at everything, look at our social media intakes, look at our sleep behavior, look at things that we haven't even considered yet. I think that's where the next big breakthrough is going to come. So we're hoping that people will buy in and want to participate in this and help us move the needle.
What about looking at your diet? I mean, we talk about sleep habits and such, but we had some news recently that low carb, low fat, they pretty much have the same outcome. But when it comes to heart disease, how does that play into it?
Well, we know, traditionally speaking, a heart-healthy diet involves eating fruits and vegetables, avoiding saturated fats. This recent study was quite exciting in that more currently people have been following this low-carb diet thinking that they'll have better outcomes in terms of weight loss, and this recent study showed no difference in outcomes. What they did notice is that refined sugars, processed foods were less beneficial. The follow-up was a little bit shorter term, but it was still an interesting finding.
So news about the diets, and you have the technology, and you have the research. Do you see, hopefully, a downward trend in heart disease? I mean, we had talked about this before, where the gap between men and women when it came to heart disease was quite vast, and now that gap is closing.
Yeah, it's actually very exciting because for a long time, that gap was quite large, and there were a lot of marketing campaigns and public policy campaigns to try to identify ways to educate women. Up till the late 2000s, more than half of women didn't recognize that heart disease was their #1 threat, and certain ethnic subgroups didn't realize it even more. So a lot of educational campaigns and work done by large institutions helped identify that. So women are starting to realize that when I have these symptoms, I should seek attention. I should take that time for myself and exercise. I should take that time and sleep. I have to put my own health first, which for the first time ever, we've seen kind of the drop in death for women. Now, unfortunately, it's still the #1 killer of women in this country, and 1 in 4 women will still die from heart disease.
And Lisa, I think you're right. I think that over time there has been a demonstration that heart disease in men and women has been on the decline. And I think that's a really good demonstration of the fruits of actually investing heavily in cardiovascular research. We've talked a lot about precision medicine and cardiology, and I think that what we're learning now is really taking us sort of to the next level. We, for example, at Stanford are focusing a lot on the genetics of cardiovascular disease, and the exciting thing is that all of the research that has been done in the world of cardiovascular genetics is now starting to be used in the clinic. So in the clinic now, we can actually test for different genetic conditions. And I'll give you just a good example of a case where this really played a big role. We had a young lady who came in, and she had atrial fibrillation, and this irregular heartbeat that we've been talking about. And it's something that we don't usually see until much later in life, but she had it when she was in her 20s, and so that was very unusual. And when we started digging in, we found that her brother had it, and so we started suspecting that there was something genetic. And we did, on a clinical scale, we did some genetic testing and found that she actually had an abnormality in a gene that was linked to abnormal heart tissue. And that really guided our recommendations. And so I think it's a good example of how the research that has been done in genetics has led to actual clinical care and clinical practice that is having this great effect on outcomes in people.
And when you hear patient stories like that, that sort of drives the research, doesn't it? In terms of finding a new cure, finding a new treatment, and not just giving up after the diagnosis.
Yeah, I mean, I think that we can't forget about this hidden risk. We've heard about decade after decade of improvements, and a lot of that was because of a few really key anchoring risk factors that we treated through public health efforts related to smoking and blood pressure. But actually, some of these trends have started to plateau or even worsen, and I think we're seeing that because of the obesity epidemic, the increase in diabetes. A lot of this is diet related, and Americans becoming much more sedentary. But we have to figure out how to get at this genetic risk. I always think about Winston Churchill doing everything wrong, smoking, drinking, overweight, stressful, living to his 90s before he had his first stroke. And then Jim Fixx, who was the father of the fitness revolution in the US, who wrote New York Times bestsellers about the merits of exercise, and of course he was found dead on the side of the road at age 50 with triple vessel coronary disease. So we've got to figure out where the remainder is, and you know, research has a very long incubation period. People have to be patient because it takes years or decades to acquire the samples, to analyze the samples, for our computer processing capabilities to catch up. I mean, we're dealing with 3 billion base pairs and now hundreds of thousands or millions of patient samples. You know, this is just on a scale that's never been done before. So it can take over a decade to have an idea and turn that into a therapy. But you know, if the government is going to support it, the American Heart Association is going to support it, you know, I think that we can keep getting at this hidden risk.
You always have to have that light at the end of a tunnel. So when it comes to treatments or procedures or surgeries, all three of you chime in here. Do you see a trend where these surgeries or procedures are less invasive? Because, you know, patients understandably are fearful of what's going to happen in that OR.
I mean, I think that we're seeing that within the last decade, multiple surgeries that were previously always done through large sternotomies are now being done through mini thoracotomies. And even more so, now they're replacing heart valves through the arteries. And so surgeries that used to take 3-5 days, inpatient stays in the hospital, are now you're in the hospital for a day and oftentimes going home with a new valve.
And that's where the technology comes in too, right? To make it less
Absolutely.
invasive.
Yes. And you know, it's pretty amazing when you walk into one of these procedures now. You know, these surgeries that used to happen 20, 30 years ago aren't being done anymore because we can do them with catheters. And it's amazing. You walk into one of these rooms now where this procedure is being done, and you can see the 3D model of your heart on the screen alongside the electrical signals that are from the inside of the heart, and then you can see the ultrasound from the inside of the heart. So all of these technologies have really come together to allow us to do more minimally invasive procedures to take care of things that used to require open heart surgery.
You have 3D models, you have virtual reality playing a role as well. What else do you see if you looked into your crystal ball in the future of heart disease prevention?
Yeah, well, I think that we need to think outside the box and, you know, not exist in our traditional silos. So Stanford is really interesting in that, you know, we can integrate across the campus with the business school, the law school, the engineering school, computer science, and you're seeing this cross-pollination. You know, our engineers are you know, some of the best in the world, and you're starting to see some of these technologies, nanoparticles, 2 nanometers in diameter, and when we leverage that amazing technology with some of our biological insights, we can make Trojan horse particles. The idea here is that we can say, all right, I know what this particular cell will go after. I'm going to attach a drug to my little nanoparticle, and it's going to deliver that drug at the right dose to the right cell type at the right time in a way where we can get over toxicities that you might have if you gave the medicine systemically. So, you know, this is all down the road. I don't mean to say that this is ready for prime time yet, but I think moving into this kind of new era of blending disciplines, thinking, you know, more broadly than we have in the past, that you're going to see some pretty amazing breakthroughs.
When you, sorry, go ahead.
And actually, Nick, just speaking to kind of the cross-pollination, I mean, even partnering with behavioral psychology, looking at patient adherence. So, you know, we prescribe 3 or 4 medicines to patients to take for their blood pressure. Most studies show that, you know, a lot of them aren't able to take what we're asking them to. So having partners in behavioral psychology, creating tailored plans for these patients so that they can implement the strategies that we've set forth is very important. But
here's the challenge too. To adhere to those recommendations takes responsibility, and responsibility on the part of the patient. How do you get patients to adhere to your suggestions, to your guidelines? I mean, you had a story that you had mentioned before that a young mom didn't really realize that she was having heart problems until her 10-year-old son told her.
Yeah, you know, I think it's actually a two-way street, to be honest with you. I think that it's, yes, the responsibility of the patient, but it's also the responsibility of the provider to recognize what is capable to be done in that situation. So for that young mom, it took her 10-year-old child to say, go to the emergency room. And of course, she was diagnosed with a very rare form of heart attack called dissection, so spontaneous coronary artery dissection. And then when we told her about the medicines she would be on, the regular visits she would have to do, when she looked at me, she said, I have 2 jobs. Yeah. I have 3
kids
children.
To raise, yeah.
Your parking situation is challenging. Among many things, there were a lot of barriers. So then we started to get at the heart of what we could do, and we tailored some of our treatment plans so that it was reasonable for her to meet us somewhere halfway in the middle. But it's the traditional model of you go to the doctor's office and they say, do A, B, C, D, and E, and you walk out and we'll do it. I don't think that exists anymore.
And the technology, the gadgetry helps in that aspect.
Absolutely. So, there are lots of different approaches that are being tried right now. So what we have to do is make access easier to certain patients. And so there are apps that I think, Abha, you're working with, and simple things like texting patients that they should do certain tests or remind them to take certain medications. Simple things like that have been shown to be quite effective. So I think that as we have more and more access to instant technology, as we're able to monitor people continuously and provide instant feedback, we're going to be able to give patients the kind of access that they need to help improve their health outcomes.
And that instant feedback sort of drives the research to go beyond in terms of how can we help that doctor-patient relationship.
Yeah, I mean, I'm not an expert in this, but you hear about some of the technology that Marco's group in the electrophysiology division is working on. These Apple Watches can be continuously monitoring your heart rhythm, and instead of having a cardiologist reading the EKGs, which takes quite a lot of time, why not have a machine learn how to do it for you and do it in an automated fashion? You're starting to see this where it can give you an alert and say, I'm not sure, but I think that you may be having some arrhythmias that might need to be addressed. And so that can work for heart arrhythmias. Some of these patients, you can tell if they're going into congestive heart failure by changes in how much volume they're retaining and if their body weight is changing. Oxygen saturation levels. I mean, there's just so much new data input coming, and I think a lot of it is time, and getting a patient to Stanford Hospital through the Bay Area traffic can be tough. So if we can do a telehealth visit, if we can rely on the technology to try to sift through the data that's in front of us, I think we're starting to see some patterns that could really expedite care.
And do you see that increase in telemedicine and in telehealth, where it's not the traditional, I need to make an appointment to see my doctor face-to-face?
I think there will be. I think that as we talk about easier access to care, I think telemedicine will play a role. There always will be a need for certain patients to come to a brick and mortar hospital to get attention. But we do need to figure out how to reach more people and how to provide better access, because not everybody lives near a hospital.
Not everybody is up to date on the latest high-tech gadgets.
That's right, yeah.
I mean, for example, one of the things that we're working on is in pregnant women. We know that pregnancy for women oftentimes is their first stress test. So if they fail that stress test, they get hypertension or high blood pressure, get gestational diabetes, that's a marker for future risk for them. So we are trying to intervene on them early. But after a woman has a baby, she's busy. She doesn't have time to come into the doctor's office. So I know you guys are smiling, but trust me, I know. But
yeah, we know.
But so we're using texting programs to reach out to them to work on things like healthy diet, weight loss, working with our behavioral psychologists, and really getting them to get up, stay active, take time for themselves, so that at 1 year they can get back to their pre-pregnancy weight, which we know reduces their overall risk. So we're utilizing some of this technology in real time to hopefully influence outcome down the line.
Well, when you talk about influence, let's use our remaining time here to give a takeaway from each one of you to our Facebook viewers in terms of giving them some advice to keep their heart healthy. So let me start in the middle with you, Marco.
Okay, so we've talked a little bit about diets, and I think one of the things that we're learning more and more is that fresh food and staying away from processed, simple carbohydrates like sugars is important. So I think we're learning to appreciate that more and more with examples like the Stanford diet study. So.
Nicholas?
I'd say get outside and exercise. It's too easy nowadays to stay indoors and get distracted by life. So stay fit. And I think the other thing is support research, because that's the way forward. So whether that's by donating your time, donating your information, your DNA, whatever, participate in research if you're given the opportunity, because that's the way that we'll make the next breakthrough.
I do want to touch on that a little bit in terms of clinical trials. How important is that in your research? And then really treatment as well.
Oh, I mean, you can't, truth can only be discovered through clinical trials. Otherwise, we're just full of hypotheses but no evidence. So my mantra is that every patient that comes to my clinic hopefully is going to be studied in some way, whether that's filling out a survey or actually getting enrolled in a double-blinded clinical trial. It doesn't really matter so long as we're helping grow the body of knowledge that will move the field of medicine with a capital M forward.
Okay.
And it's particularly important for our female patients because traditionally they've always been under-enrolled to many studies in proportion to what they have the disease. So I would encourage our female patients, in order to find the treatments that work best for you, we need to actually study how they work. Up till recently, all of our guidelines on how to treat heart disease in women was largely based on research done in men. Mm-hmm. And so until we are engaging in the research that is happening, we are not going to be able to find better solutions for us.
And when it comes to women, sometimes their cases are misdiagnosed. It's a part of not just the physician, but the patient herself not taking care of her health because she has to keep going and going and going.
Yeah, and I think that would be my takeaway. I agree with these guys, but I think the key thing is to be an advocate for yourself and to know that what things are appropriate for you and what things are not. And when you're not sure, to seek attention and to take that time to take care of yourself. I think it's extremely important.
So take care of yourself, use the technology, and get involved in clinical trials because, really, that's the bread and butter of your research, right?
Absolutely.
Okay. Well, you can get involved in clinical trials and get more information if you head on over to our website, stanfordhealthcare.org. cardiovascular health or /cardiovascular health. Once again, thanks for joining us tonight for our first Facebook Live here at Stanford Healthcare. I'm Lisa Kim, Dr. Ava Kandawal, Dr. Marco Perez, and Dr. Nicholas Leeper. Thanks again for joining us tonight. We hope this is just the first of many conversations to come here on Facebook and Stanford Healthcare. Good night.